Thanks so much for coming today and letting us talk to you about what we're so passionate about, which is trying to identify how to treat and cure autoimmune diseases. So I know you've already heard from two outstanding scientists, and you're going to hear some things again. I always figured that helped. In medical school, they told me, since I was a little overwhelmed by how much there was to know, they said, if it's really important, you'll hear it 3 times. So today, you'll probably hear a few things 3 times. But I think that will also help you understand that each of us is embracing these questions, thinking about the same model, but using our different expertise. So I'm going to give a little bit more of an overview, and hopefully that'll help, and I'm happy to take questions at the end. So as I was told, we're going to talk about autoimmune disease today, and I'm going to talk about it more generally and not about any one specific disease. And what are they? Why do we get them? And then what are we going to do to try to treat and cure these diseases? So who gets autoimmune disease? Well, the first thing you need to understand is that there are over 80 autoimmune diseases. So they're complex. There's multiple autoimmune diseases. There's 16 million people in the US who have an autoimmune disease. They can be diagnosed at any age. You can be diagnosed at age 1 with type 1 diabetes. You can be diagnosed at age 80 with rheumatoid arthritis, and anywhere in between. And we'll talk a little bit more about that. I'm happy to address questions. And as has already been noted, autoimmune diseases affect women more often than men at a ratio of 3 to 1. And that's one of those very interesting things that helps us think about what is the cause of autoimmunity. So when we get back down to who gets autoimmune disease, 1 in 20 Americans has an autoimmune disease. And it's among the top 10 causes of death in children and women under age 65. So these are important diseases, even though each of them individually is quite rare. And the cost of these is nearly $100 billion a year. And part of the cost is, in fact, not only how much it costs to care for a person, but it's really, truly the disability that these chronic diseases cause. So let's get back to what is an autoimmune disease. And I think this is really important because so many of us come to this question from our own disease or as a physician from our own specialty. But these diseases cross different diseases, ages, specialties. So here's a list of some autoimmune diseases. It is not all of them. And these diseases can affect the skin. Psoriasis is probably the most common autoimmune disease of the skin. They affect the blood. People can have diseases where they bleed because they have low number of platelets. They can be anemic because their antibodies destroy their red blood cells. There are certainly diseases of the nervous system. Multiple sclerosis is the one we're most familiar with and is most common here in the Pacific Northwest. Diseases of muscles and joints, so I'm a rheumatologist and that's my bag, and so rheumatoid arthritis is one of the most common autoimmune diseases affecting 1% of the population. But you also heard today about systemic lupus, Sjogren's syndrome, and a disease that affects men more than women, ankylosing spondylitis, all fall into these muscle and joint diseases. Certainly diseases of the endocrine system, type 1 diabetes, thyroid disease, which is probably one of our more common autoimmune diseases, are among those. And then diseases of the gut, so Crohn's disease, ulcerative colitis, even celiac disease are caused by the immune system. And then each organ actually probably has its own autoimmune disease as well. There's inflammatory diseases of the eyes, diseases of the kidney, and certainly diseases involving the lung. So autoimmunity is a lot of different diseases, but what I want to convince you today that by studying many diseases, we actually can understand the source of autoimmunity really at its basic, and then move on to do better in terms of developing therapies and cures. So this is the world's most simple view of the immune system. I'm going to move here so I don't have to look over there so much. And that is, how does our immune system work? And, the dermatologists tell you the skin's the most important organ because it protects us and it's the largest organ. But in fact, I think our immune system is the most important organ, and its job is to protect us from danger. and it will protect us from infections and from cancers and foreign objects, and its job is to detect danger and destroy it. And as I've noted, danger is really infections and cancers, and part of the balance here is that it's going to protect us, but because it's a destructive force, it has to be controlled so it doesn't lead to further destruction. So I stole this from Jerry. So what the immune system needs to know is when to start, so when to put on the accelerator, and when to stop, so when to put on the brakes. And that's what is really central to what we're asking here. So if you have an immunodeficiency, your starter is broken. You never get started and you get infections. Those are the boy in the bubble type of problems, the kids that don't have an immune system. Now, I think of allergy as a case where the accelerator gives the immune system too much gas at the wrong time. So if I eat a peanut, I'm fine. If a kid who's allergic to it, somehow they get a really aggressive immune response, that's inappropriate. You can think about a bee sting, and I get a little red spot when I get a bee sting, but someone who's allergic to bees will actually get a huge amount of inflammation and be very, very ill. So the accelerator gets pressed way too hard. And then in autoimmunity, we believe that the brakes fail, that you develop immune responses that you don't control. And we're going to get into that kind of thinking in a little bit. So in autoimmunity, the immune system is out of balance. It's an immune system that detects danger in normal organs in the body, so it makes a wrong call on what's bad, and then it doesn't stop. And what ends up happening is you get injury to a specific organ or tissue. So just globally, what are our goals as scientists and researchers? And of course, the things we want to know about these diseases is how to diagnose them, how to treat them. We'd really like to cure them. And as Judy said, the ideal goal is to prevent them from ever happening. And so that's where our vision is as we think about a problem related to autoimmune disease. So really the question is, how are we going to do this? And am I crazy? Can this really happen? So I'm hopefully going to tell you how we think about doing this in a general way, and then what I think we're going to do to make it happen. So when we think about doing medical research, I kind of decided to go back to the real basics. Part of this is I was giving a talk to the residents at Virginia Mason the other day about an autoimmune disease, and it made me think about what I teach a medical resident when I talk about a disease, and then how does that apply to taking that information back to the lab. So the first question we have is, what is this disease when we see a patient and we describe the disease? We have to think, what is the source of the problem? You come in and you can't walk. You may have broken your hip because you fell down the stairs, or you may have rheumatoid arthritis that's keeping you from walking. So as we describe a problem, we have to figure out what's actually wrong in the body. The other question is, who gets this disease? So frequently when we describe a disease the first time, we think about, what is the type of patient that gets the disease? Are they men? Are they women? Are they young? Are they old? Why does this happen? And I'm going to talk mainly about that question today. And then how can we treat, cure, or prevent that? So that's as I think about a presentation I give to a group of doctors about a disease. These are the questions I'm going to answer. And I think they're fundamental to how we think about doing research. I made this little picture, and the point I wanted to make with this picture is this is really an iterative process. First, we figure out what's going on, at least in the big picture, who gets it, and some thoughts about why. But we have to keep going around and around, and finally, we can actually understand a disease well enough to impact it and treat it. So I'm going to start by talking about the question about what is the source of the problem in autoimmunity. And in autoimmunity, as I said, the issue is really the immune system attacking itself. And this is a picture of an islet. And so this is a healthy islet. This is from the pancreas of a healthy person. This is where you make your insulin. And this is the islet of a person with type 1 diabetes. This may actually be a mouse, to be honest with you. I should check on that. Big controversy in diabetes. But anyway, what you see here is a lot of black dots in the middle of this organ. And those black dots are lymphocytes. Lymphocytes are B cells and T cells, and we've already heard a lot of talk about those this morning. So they infiltrate and attack the organ, destroy it so it can no longer make insulin. So we know the what is the immune system attacking healthy tissue. So then there's the question about who gets disease. You know, we want to know, is it the young or the old? So let's say if it happens in older people, is it due to aging? If it happens in the very young, is it due to a genetic problem? More often in men or women, again, that raises the issue of hormones. Does it happen in families? And that kind of highlights the question of, is it a genetic disease? Is it linked to a lifestyle or a location which would implicate environment? And the point is, as we over the years have described these issues, and much of this work has already been done in autoimmunity, we've learned that each disease has its own story. There's a different answer for type 1 diabetes than there is for lupus, but they share many common features. And so that's a point that can be a target for our understanding and our analysis. So why does this happen? Why do people get autoimmunity? We know it can be due to inflammation. We know that the immune system's out of control. We know that genetics play a role because they run in families, and we know the environment is important because we know certain habits, certain locations are associated with disease. And so my point here is that this is the big question for us right now. How does this happen? What roles do each of these play in developing autoimmune disease? So we talked a bit about this before in terms of the causes of autoimmunity, and I am going to point out that it's complex. You probably already figured that out when you looked at Karen's slides of the immune system. It's complicated. We know that the immune system is not well controlled in autoimmunity. We know that the people that get it, there are genes and environmental factors. And so when we think about autoimmunity, people are born with a genetic predisposition for it. We know that those people probably have baseline changes in the way they respond immunologically. And those set them up in the setting of either hormonal factors, infections, or exposures that then put them in a position where they have an abnormal immune response that attacks cell tissue. So and you don't control that attack the way you normally would. And that leads to autoimmunity. So we think of it as a multi-step process over the course of time. This process can happen in a matter of months to years in some of our diseases. In other places, we think you sit here for a very long time before you get enough exposures to get to the point where you actually have disease. So just briefly, genes certainly are known to contribute to autoimmunity. This is just looking at all of our chromosomes, and this is a highlight from a few years back of the genes that are linked to lupus. Now, this is from 2009, and this just shows you where we've gone over the last 10 years or so. We now have mapped multiple genes, and all these little colored points are different places in your genetic code that are linked to an autoimmune disease. In the setting of type 1 diabetes, there's over 60 different markers in the gene that link to risk, and that's similar for other autoimmune diseases. So we know a lot about the genetics now. One of the things we learned, as Karen pointed out, is that the genes that are linked to autoimmune disease are actually genes that are important for immune function. So we're on the right path. The other thing it taught us is that the genetics of autoimmunity is very complex. Probably not a surprise because these diseases are complicated. And this complexity may in part help us understand why different people are different, this heterogeneity in disease. We're using genetics to look at each of these individual markers to help us understand what's wrong with the immune system, knowing that if we study one marker in autoimmunity, it's going to help us understand potentially what's wrong with the B cells. Another marker may help us understand what's wrong with those T cells or why you have the wrong population. And then we can start putting this puzzle together. So one of the most interesting things about these complicated genetic studies is actually when you start looking at the genes, and these studies have been done in many autoimmune diseases, what we found is that they share many common genes. So that gets back to my original hypothesis, that autoimmune diseases actually have many things in common. And by studying the commonalities, we actually learn more and get better at treating them in general. And here you just have a very nice example of some genes that are linking these different diseases. My lab has been studying a gene, PTPN22, for 10 years now that is found in lupus and rheumatoid arthritis and type 1 diabetes. Interestingly, it's not involved in MS, psoriasis, or IBD. So I think what it's common to is very interesting, and what it isn't common to. It's also interesting. Another gene that Karen and another colleague, Alice Lawn, study is a gene that's involved in that IL-2 signaling process she talked about. And that's found in MS, and it's also found in type 1 diabetes. We think that's very important. And then lupus patients have the opposite problem with IL-2. So there's this kind of IL-2 story in those three diseases. This is helping us think about what's wrong with the immune response that's common in these diseases, and then as we think about which therapy to target, that's going to help us do that as well. So I know Dan talked a bit about the T cells and the immune response, and so I thought I'd put this picture up just to make the point that as we understand how the immune system works, it helps us understand what's wrong with it. And so this is a slide I use when I teach the medical students, so I would like you all to memorize it. But it just shows, and it does actually show that I think a lot about T cells. That's Jerry's fault, because I trained with him and he thinks about T cells. But B cells are important. I have them over here, and antibodies are important. But what it shows is just that there's a pathway from the development of the immune response to maturation of the immune response, that in the right setting will help us against infections and cancer, in the wrong setting leads to disease. And there's this other cell here called a regulatory T cell that stops that from happening. By studying each aspect of this pathway, we can find out what's wrong in each individual autoimmune disease. And this I just show because actually I want us to understand that we don't just study autoimmunity when we study the immune system. And in fact, one of the very interesting things is that there's many types of T cells that are made to protect us, but they also injure us. And so I just thought I'd show you, and I think Dan talked a little bit, I don't know if you mentioned the snowflake theory of T cells, but there are quite a few different types of T cells, and we've started to understand that. We know there's a type of cell, this blue Th2 cell, that's very important for protecting us from parasites and worms. Luckily, we don't get too many of those, but when they go wrong, they lead to allergy. We know that these cells, Th1 and Th17 cells, protect us from viruses, they protect us from things like tuberculosis, and from fungal infections, so they're very important, and if you don't have them, you have these problems. But these are the same types of cells that lead to these problems, and these are just pictures of the skin diseases: psoriasis, Crohn's disease, the rash of lupus, the infiltration of an eyelid in diabetes, the brain of someone with MS, and of course the inflamed joints of someone with rheumatoid arthritis. So we know these cells are important, and I'm going to get back to why knowing that they're important makes such a difference therapeutically. And then we know that there's these regulatory T cells that actually protect us from autoimmunity. That's their job. There's some people who are born without these cells, and they get horrible autoimmune diseases, multiple diseases. But what we've also learned is these guys are kind of the bad guys in cancer. And they stop your immune response from getting rid of your cancer. What's important about this is we now have therapies that stop this process and that are being incredibly helpful in cancer therapy. So you can imagine how the immune system is important across many diseases. And as we learn more about autoimmunity, we in fact learn more about allergy and cancer and infections. So I thought I'd just mention a few examples of environment, because I know people are always interested in this one. It's maybe the thing we can control. So just some examples. Geography has been shown to be important in autoimmune disease. The risk of MS is increased if you live north of the 45th parallel until you're age 14. That's us. And the question is it sunlight? Is it because of vitamin D? That's one hypothesis. There could be others, but I think it's intriguing. It gives us a clue. We know infections can trigger autoimmune disease. A classic example is some forms of infectious diarrhea will trigger arthritis in people with a certain type of gene. So genes are important in the infection. We know your habits can affect autoimmune disease. Smoking doubles your risk of rheumatoid arthritis if you carry the risk genes for rheumatoid arthritis. Drugs can certainly impact you. There are certain drugs that actually cause a type of lupus. But we also know from some studies we did collaboratively with the group in Denver that use of contraceptives at any time in a woman's life decreases her risk of developing rheumatoid arthritis. I thought that was amazing. Diet certainly is something that many people are interested in studying. One of these very interesting small demonstrations of this was that there was an epidemic of celiac disease in Sweden in 1985 through 1987, and it was linked to a change in the introduction of cereals at a certain age. Now, you could only do this study in probably a Scandinavian country because everyone followed their doctor's directions, and the doctors all gave the same directions. So they were able to trace a change in the guidelines to this outbreak of celiac. So intriguing, probably hard to do in another setting. But all of these demonstrate that there are many different types of environmental factors that can impact autoimmunity, and they're, of course, difficult to tease apart, but that's part of our job as we think about why we get it. One point with all of this is you need to have the wrong genes and an environmental trigger. You can't have just one or the other. All these kids who got celiac disease carried the gene that leads to celiac disease. The smokers have to carry some of the genes for RA. So that's an important point to keep in mind. So how are we going to treat these diseases? And that gets me back to this kind of circular discussion about looking into this. And I think first we have to understand the complexity of the immune system. I think we have to understand that there isn't one simple answer, but that we're probably going to have to treat multiple pathways. We're going to have to determine how the genes contribute to disease. And I think one of the things I want to really focus on today is developing new tools to study autoimmune disease, and then take our discoveries from the bench to the bedside. And that's really the focus of what we do here at BRI, so I'm very invested in that. Again, we need to repeat this until we get the whole story, because frequently it takes time and many observations to get the whole story about a disease. So I'm just going to talk a little bit about the tools that we use to study autoimmune diseases. And some of them are new tools, some of them are old. So my first tool is to study the patient. And that may seem really obvious to all of you. But it's something that we have been doing for quite a while now, and of course is vital. So what we do is we have our patients who participate. They're either healthy subjects. Here we have Kay Brantz, one of our employees, giving a buccal swab sample so we can look at her DNA, and one of our great coordinators, Kevin. But what we do is we have healthy subjects and people who have autoimmune diseases referred by their physicians, and then we're able to get blood samples from them, but also clinical history, so we understand what their autoimmune disease is like. Because I told you there's heterogeneity. This is an important part, collecting all of this information. And then we keep that in a registry and repository, so our scientists here at BRI, when they have a good question, can ask it quickly, because they can talk to my manager of the clinical core, son, and he'll pull the sample out of the liquid nitrogen freezer, and he'll give it to the scientist who needs it. Karen will look at B cells. Dan Campbell will tell you some pretty exciting stuff about T cells. So that's the idea. How do you do this? Well, what's really important is we collaborate with clinicians. They're really the experts in the human side of these diseases. We link lab data to disease-specific pathways, so we can start understanding which part of the disease is being affected. And we develop biomarkers for treatment using this approach. So other new tools. So a tool that's been developed here by Bill Kwok is to study single cells. So I said, take it one cell at a time. And it's kind of amazing technology. Many of you who've heard us talk before have seen examples of this. That he's created something called an HLA class II tetramer. This is something that can identify a T cell very specifically to its target. So a T cell that is going to help you when you get influenza, he can find them in your blood. Or if it's a T cell that can attack your joint, we can find those in your blood or in your joint. So how I've tried to show this is if we take a drop of blood, only a few of those cells will light up using this tetramer. That allows us to look at the cells we think are most important. It allows us to tag those cells with many different colored markers that allow us to understand each individual cell and what it's like. And this is just showing one of our fancy machines. And this is just showing what we can do. We can actually see these are the cells that all recognize the joint. This comes from work that I do with Eddie James, who runs our tetramer core. But we can also say, yeah, we have these cells. We can count those cells in the blood. But we can also use other markers. You don't have to memorize these, that tell us something special about the cells. These are Th1 cells. Those are cells I showed you before, and I'm going to show you again. But something else we've learned to do is to take these cells and sort them and study them one cell at a time. And this is done in our genomics group. This is work from Peter Lindsley, where he can take these cells, and each of these red lines tells you something unique about one of those cells. So we can actually understand not just what the bulk group of cells look like, but what each individual cell looks like. And this is a really powerful tool that we're pioneering. So these tools let us know what type of cell they are. That's going to be important for directing therapy. When do they appear? So questions we're asking using this tool is, if I look in the blood of a person 5 years before they get diabetes or rheumatoid arthritis, can I already see these cells? If I can do that, can I predict they'll get disease? And if I can do that, can I prevent the disease from happening? Can we make these cells go away? And so we're studying this as well in patients with autoimmune diseases. We're following them before they start treatment and after they start treatment. Also, Eric Longray here at BRI is doing this in allergy, and he can watch the cells go away with allergy therapy. So it's a really helpful marker of response to therapy. So another way to ask this question is to look at your blood and do this transcriptomic approach, which I think has been touched on. So I said looking at blood one drop at a time. So here's a technology where we can take a very small volume of blood and we can look at all of the genes in your blood. And this is showing that gene A is turned off, gene B is on, and gene C is on. And we can differentiate. These are just looking at the blood from healthy subjects and the blood with lupus patients. And they're getting sicker as we go along in this graph, and you can see how they look different from healthy people, and you can see when people have more severe disease. This has taught us a lot about monitoring lupus, but maybe more importantly, it's told us which genes are important to see in active lupus. This is an example of someone with a group with arthritis who don't look like lupus patients at all. So. And of course, we can take this therapy and give a patient a drug and watch how that therapy changes. And I didn't put that slide in, but we actually have evidence where we take kids with juvenile arthritis, treat them with a drug called anakinra, and you see complete reversal of the changes that had happened in their disease. And then the other tool that I think is really very important is to integrate the data so that we can increase our knowledge. And so this is an area that's become really important for us, is to take these big data sets, integrate the ones that we drive with data that comes from the outside world. Karen discussed the GeoDatabase. We take that information, we integrate it with our patient data, and then we can start understanding it, graphing it, visualizing it, so someone like me can actually figure out what's going on. But it allows us to take huge amounts of data and all of a sudden make it understandable. So I think that's an important place for us to go forward, and it made me wish last week I had taken linear algebra. So kind of terrifying. Jerry informed me that I would have forgotten it by now, which is correct. So I guess I just need to meet someone who's taken it. Anyway, so here is our picture I promised I would bring back to you. And I think the important thing is if we understand the immune system and then we understand what's wrong in this pathway, it helps us understand how to treat it. And so what I just wanted to show you is something like what Karen showed you. It's a little bit more drugs, and it's not completely up to date. So what we're able to do is say, is the problem with activation in the periphery? And there's a whole series of drugs that have been developed to target these cells. Karen talked about drugs that target B cells, which we make antibodies. We can target those bad Th1 and Th17 cells with a series of drugs, some of which are in the market, some of which are in clinical trials. Very exciting in terms of responses for multiple autoimmune diseases. We can help the Tregs work better, and Karen mentioned this IL-2 therapy. There's also people who are infusing regulatory T cells into patients, and there are other drugs that may help Tregs. And then there's drugs that keep the bad immune cells away from the tissue they're attacking, and these have been quite useful in the setting of multiple sclerosis and inflammatory bowel disease, and they're going further in the clinic as well. And then there's the drugs that actually target what's happening at the tissue site. Things that block cytokines, and Karen mentioned tocilizumab, and of course the anti-TNF drugs, and there are others as well. My point with this slide is that by understanding and doing very basic research, we understand these pathways, then bringing it to patients and understanding which diseases there's a problem at where, we've actually now got a whole series of drugs we can use to treat patients. So we've come a long way. Of course, our goal is to get better drugs and to use them at the right time in the right patient. So that's where we're going, but we are actually at a very exciting place in that path right now. So research is really a pathway to a cure. If we understand why people get autoimmunity, that's the first step for us to help understand how to help those patients. Here at BRI, we do that by integrating clinical trials, laboratory discovery, and also using the samples from patients to mark, predict, and prognosis in patients. And these all kind of intersect with each other, again, in an iterative fashion. And I think that's going to help us understand why people get disease and then help us figure out how to treat them, and I think, importantly, how to cure or prevent them. So that's where I'm going to end. Oh, I got my sign. It's a high-tech sign back there. And so I'm happy to take questions.
So we've been talking a lot about prevention and being able to test genetically. How do you envision that happening, like a genetic test at birth? Like my parents would never have known,
yeah,
even if it was available, to take me in for genetic testing. So how would we identify those people that needed to be tested and get that done?
That's a really great question. So I think there's two parts to that question. There are some genes that are very helpful, and a lot of what we know about the genetics may not be so helpful because it's so complicated. Some of the genes that you could have that put you at risk may only put you at a very small risk, and actually may not be bad to have in the normal setting. But there are a few genes we know are very strongly linked with autoimmune disease. The HLA genes are the ones that are most prominent, most important genes. And actually in type 1 diabetes in family members now, they do studies where the children are typed for that gene and followed over time. That's a case where we're already doing that and trying to get kids into trials to try to prevent disease. So that's ongoing. I think we'll find some genes that will help us. Sequencing a whole genome has become quite cheap, actually, so we can get the information. The challenge for us is going to be how to use that information. And I don't think genetics is going to be the only screening tool we use, but it may help us, particularly if we know there's certain exposures that we need to avoid early, that genetics may help parents know to avoid that. Yes?
So BRI has so much great data. Do you collaborate with other research facilities and share that data and exchange your
Yeah, so I think that's really important as we think about the tools we talked about. How do we use them and how do we benefit people with autoimmune disease the most? And one of the major parts of our program is to be collaborative and to be integrated with multiple networks. And I didn't emphasize that here. So our biorepository, we send samples all over the world to scientists interested in asking questions. And then the important part is we can bring that data back and look at what their data means in the context of what we need. So we're actively doing that with our registry and building databases that allow us to do that integration. The other thing we do in clinical trials is we're part of large networks where we're recruiting the 5 to 10 patients in that study, in a study of 1,000 patients. So we're integrated in that respect. And we do quite a few projects collaboratively with people, not only in the US, but worldwide, so that I'm really excited about studying a certain gene, but my lab's really good at studying how that works in B cells and T cells. Another lab may be able to develop a beautiful animal model that can answer questions I can't answer. And so what we do is we write grants together and we work together very closely. And I think that's the best way for us to move forward. Yeah.
How can we participate in your repository or your clinical trials?
Excellent question. So I think we have the information out here because we do have a group. We have several groups. We have a clinical trials group who can give you all the information about the clinical trials that are going on. And then we have a translational research group who have people who are participating in our registries and repositories, giving us blood samples and information so we can study them. And that information is right outside. You can contact them and they'd be happy to talk to you about it. We're also always putting a big plea out for healthy subjects of all ages because it's important to, whenever you study someone with an autoimmune disease, you have to have someone to compare them to. And so that's become one of the most valuable things that we have at BRI is a very large group of healthy volunteers who help us do our research. Other questions? Yes.
You talked about the process of autoimmunity and how inflammation plays a role in it. And I'm wondering if there's specific research being done in trying to prevent people going from the high inflammatory state into the autoimmunity.
Yeah. So I love it when I get to talk to an audience like this because you guys ask all the best questions. That question in the back to Karen was a great question about what happens when you treat people and their immune system changes. I loved it. But also there's a question of how do we go from that part where they've just started to show that they've got an abnormal immune response, but we don't want them to get to autoimmunity. And so the way we are trying to address that question is to look at groups of subjects who we know are at very high risk for autoimmune disease. They're typically family members. And we're following them over time to see how their immune system changes over time. And is there a point where we can see that kind of the flip is switched and you're going to get disease? And we know in diabetes that if you have the wrong genes and you have a single autoantibody that you have autoimmune disease, but you may not get diabetes. If you get 2 autoantibodies, that switch is flipped, and someday you will probably get type 1 diabetes. It may be next week, it may be 20 years from now, but you're already on that path. And so that's a very important area of study, and we're studying those samples to understand what parts of the immune system have changed. And it's important for us because if we can detect that early, we can go in and reverse that with a medication. And I think most of us believe that to prevent disease, we have to go in very early and kind of reset the immune system or re-educate it. Yeah.
This is just to clear up my own confusion on the use of the word inflammation. Is that a cause or an effect?
That's interesting. Yeah. So we can say inflammation or abnormal immune response because you're right. Inflammation is the immune response. A lot of times physicians think of it as the early immune response, this innate immune response that you get within seconds of being exposed, but in fact you can have acute inflammation or chronic inflammation. It's part of the, I think it's part of the what's going on, what's wrong, it's inflammation, and then we have to back into, so what part of the immune system is misbehaving? So it's kind of a very general term in this case. Yes?
So some of these like new drugs and new treatments, are they working on halting progression rate, or are they working on actually like fixing an issue that autoimmune has caused? Like, will they reverse organ damage, or will they just stop the organ damage?
Yeah, that's a very good question. So sometimes our goal is just to, so sometimes you just make people feel better, but they still get organ damage. That's better than nothing, but it's not very good. A lot of our therapies now, we know, stop organ damage where it is. Rheumatoid arthritis is like that with many of our new biologic drugs. We know the x-rays will not go on to get worse. And also patients feel better, which is good. So we know we're there with rheumatoid arthritis. One of the things that's very interesting is to think about how do we get tissue repair plus stopping autoimmune disease. So we have to stop disease and do repair of tissue. And those are very important questions that are being addressed. You know, I think the other part is we want to get treatment as early as possible to stop, you know, the pathology or tissue destruction. And that's why in rheumatoid arthritis now, they're treating people with very little arthritis very early before they get any changes on their x-ray. And we know in that case, we can keep them from ever getting changes in their x-ray. So the better we are at diagnosing earlier, the better we're going to do there. But at the same time, for people with established disease, we are trying to figure out ways to do tissue repair in combination. Yes?
Quick question, you were talking about several factors that contribute to disease. One was genetics, one was hormones, and then you talked about triggers. Do you have any idea what these triggers could be, or how do you study that?
Yeah, well that's what's really, that's the most challenging thing to study, and I know for most people it seems like the most interesting thing to study. So the way to study triggers is either to have a marker for that trigger that differentiates people with an autoimmune disease or people who don't. So let's say there's a specific infection that would trigger an autoimmune disease. If it was rare, we could pick it up.
Yeah.
If it's common and 90% of people have it, that's going to be hard. So that gets difficult with infections. What we're doing with other groups is if we collect information about people from very early on, let's say there's a study called the TEDdy study in diabetes where children are enrolled at birth and followed over time, every 3 months, getting samples, getting information from their parents. They've actually been able to identify a group of kids who go on to develop antibodies and then go on to get diabetes. They have every infection, every vaccination, they know when they were weaned, they know all of that information so that they can get to the environmental triggers. They're even collecting stool samples every 3 months so we can get to understand if there's something different growing in their gut. That's a very interesting. So those are really hard studies to do. They take very long time and a lot of money. And so one of the things we try to do is convince the government and other groups to fund that type of research so we can get to that question. It's one of our challenges as well as just trying to understand the diseases. Yeah.
I'd ask this question of all the speakers. 10 years from now,
yeah.
What do you think? One person said prevention, the first speaker had almost an immunization, the second speaker, if I understood, I'm not a rocket scientist.
Me neither.
More of a personalized medicine identification and matching therapy to whatever the marker is. What do you see as in 10 years? What would be the big improvement?
Yeah, so I definitely agree with the prior speakers. I didn't hear Dan's response, but I agree with Karen that personalizing, being able to pick the right treatment for the patient, I think we're going to get there. I'm hoping before 10 years. I think repurposing of drugs is happening now and is really an important way to move forward quickly. Probably where I see us going in the next 10 years is using combination therapy. And part of that gets to autoimmune diseases are complex. one drug is probably not gonna be good enough. We know in cancer, one drug isn't good enough. I can tell you in rheumatoid arthritis, one drug isn't good enough. So I think if we can be really smart and target several pathways at the same time or in tandem, we actually may get a big bang for our buck. And there's some, you know, we've been thinking a lot about how do we control disease. And we're getting pretty good at that, at least some of the diseases. But there's actually some new data coming out that suggests some of these therapies we're doing may be able to stop disease in its tracks. And I think that's gonna be where I'm hoping we are in 10 years.